Next we have a 46-year-old lady, Mrs. Kasturi, who is a follow-up case of segmental tibial fracture on X-fix. She is posted for X-fix removal and cast application under femoral, lateral cutaneous and sciatic nerve block. Over to you, sir.
Professor Chan, if possible, you can show us the obturator also.
Dr. Bala?
Yeah, yes.
We are just preparing the case.
Okay.
Meanwhile, can you just discuss few points over there?
Oh yeah, sure.
Yeah.
So you're now from the upper limb, you're going to the lower limb blocks, and the femoral, we have requested Chan to demonstrate femoral, obturator, lateral femoral cutaneous nerve, and also the sciatic. And the question which Dr. Maya asked about sedation, it depends on the profile of the patient, but if you have a pediatric patient, the other thing that you could do is you can use intravenous ketamine, which is an extremely good drug, maintains the airway, a dose of about 1 milligram per kg or 1.5 milligram per kg. It keeps them very quiet and you can do a block with comfort, especially when you use blocks like deeper blocks like intraclavicular blocks. The tissue dissection is more, so you want the patient to be still, so that's a good drug. But for conscious sedation, as Dr. T.V.S. Gopal said, dexmedetomidine is indeed an extremely good drug now. It produces an excellent conscious sedation to your patient without compromising on the airway. And they're arousable as well. And the probe is getting prepared.
Bala?
Yes.
Just before you give the Dexamd, also give midazolam and fentanyl, which would be a helping hand?
So mostly in majority of the cases, we do the blocks awake. Majority of the cases, we do the block awake, because I always feel if the patient is cooperative and once the analgesia sets in, it's perfect, then why to lose the advantage of keeping them awake? Except if they're very anxious. And the minute you put any drug, it also increases the incidence of postoperative nausea and vomiting, whatever you say. So when only mandate when the patient is very anxious, you go for it. Otherwise, I would prefer to do most of my case under patient being awake. Are you ready, Dr. Sandeep?
Yes, we are. We are ready.
Okay, over to Professor Chan.
So what I'm trying to do first would be the femoral nerve block. For femoral nerve block, the important landmarks, internal landmarks, would be the femoral artery. You can see it pulsatile. The dot on the screen is medial. We know that the orientation here is vein, artery, and nerve. So when I lift up the probe, you see the vein medial to the artery. That's the artery. Then also you see two brown structures. That's the division, the bifurcation of the femoral artery. So I adjust the angle of the probe a little bit more careful at, or shift the probe a little bit careful at. You see one artery as opposed to two dividing. So for me, I don't really care whether it's this level or slightly distal. What I really care about is whether I can see the femoral artery well. The femoral artery here can look very, very bright. So I'm just getting more distally. I pre-scan her. I know that when it's distal, it's actually very nice. You can see it on the lateral side of the artery. Now what you don't want to get full is you also see very bright structure underneath the artery. That is acoustic enhancement artifact. So that is not a nerve. And you can see it in infraclavicular area as well. So don't get fooled. The muscular structure that you should look for is the iliopsoas muscle. So I'm looking at the muscle right there is a big muscle bulk. You know that the nerve cannot be inside the muscle bulk. It has to lay on top of the muscle. And sometimes you will find that the femoral nerve is very lateral. Look above the iliopsoas muscle and look on top and look for that nerve. And usually it's not a round structure, but it is either oval shape or it's like a number of branches laying on top of the iliopsoas muscle. So what you see here, very bright, very nice, that you can also appreciate is already divided in has more than one branch, you can see that there are at least two distinct hyperechoic structures on top. So for me, I have done both. I have done out-of-plane approach. I have also done in-plane approach. For in-plane approach, I favor in-plane approach because now I can see the corner. I don't even target the nerve. I target the corner. It's like an apex where I could have to puncture the fascia iliaca in order to get into that space. And also the other thing for in-plane approach is you can already do a subcutaneous tunnel underneath the skin before you get to the femoral artery. For catheter technique, that will be very helpful. So that's what I usually do. So I'm using for this lady, this is an 8 centimeter needle. Generally speaking, a 5 centimeter needle is quite suffice. So again, you have to plan. Looking at the nerve, it's about 2 centimeter deep. I'm now going at an in-plane approach from the right side of the screen and then go to the corner. So I'm going to start. The patient has been sedated. Although, ouch. Sorry. So she react. I've gone through, so I think I'm okay now. So when you go in, again, I jiggle the needle. I want to see where it is, approximately where it is. I know I'm close, so the next thing I do is I'm just moving my probe. It's on. It's okay. I can see it. So I can see the needle very well. In fact, I don't need so much depth. We can decrease the depth a little bit. After
You can
I
see here
go
it's
in.
written as 4. That indicates the depth. So
Right. So right now I'm right at the apex. So this is where I want to puncture. So usually I would use some fluid again, hydrodissect, but now this is local, right? So if it's local, I don't want it to inject and then you lose the twitch. So we just want to, okay, I can feel that. I have gone through a sheath, fascia layer. I think I'm still outside. I'm going to go pop through one more. Okay. So now I think we can stimulate. Okay, so you should look at the...
So it's a dual block. The peripheral nerve stimulator is being used.
So it's not
along with
stimulating right now, so you don't see any twitch.
So you would see the quadriceps contractions.
So right now the stimulation is not working. Stimulator is not working. We are trying to fix it.
Okay.
But you can see that I'm there. I'm jiggling. For this block, again, all I want is the local anesthetic to spread in this compartment.
Are we using the
But it's
HNS12?
0 though, is it?
Are we using the HNS12?
Pardon me?
The stimulator, is it the HNS12?
The stimulator is reading 0 right now. We turn it up? It's up, I see.
This has to be here.
Ah.
Camera. Go. This PNS.
So this is where I am.
Dr. Sandeep, is that HNS12?
Yeah, it's HNS12.
The positive electrode is fine?
Yes, sir.
Ah, it's disconnected. Now turn down the stimulation. Turn it down, yeah. Okay, now it's working. We are stimulating. And you can see the twitch.
Can you focus more on the quadriceps?
See the needle.
Yeah. Can you see the contractions now? Yes, now it's seen well. Yes.
Okay, let's decrease it, and then I think we can
Do you think that was, yeah, okay, that's fine, yeah.
we can do a test now. Again, what I really want to see is a spreading. Can I have half? Okay, so again, I am half into the muscle a little bit. I'm pulling back, Okay, half cc there. Okay.
You see, this is the
Another
fascia. This is the
2
fascia
cc
iliaca.
there.
Actually, this hyperechoic structure.
So again, I'm just looking up, looking down, right? You can see that the nerve is inside a puddle of fluid now. I'm just looking up. I'm looking down. Yeah, we can. Now, how much? So, are we going to do 3 blocks here?
We are doing lateral femoral,
Right.
posturator, and femoral only.
And this is for surgery.
Yeah.
And what are we injecting here?
2% xylocaine adrenaline, 10 cc.
Okay,
Now
2% lidocaine
Yeah,
with
and this is
epinephrine.
sensorcan. This is bupivacaine 0.5%.
Okay.
This will be 10 ml.
Okay, so this will be 10 mils for femoral. Okay, so we're planning to put in 10 mils of 0.5% bupivacaine with epinephrine to the femoral. So can we continue?
Inject?
Yes. It's very nice, very nice, very nice. So again, I'm looking up.
Dr. Sandeep, your mic is also on.
Okay, fine.
I'm looking down.
This is fine?
That's good.
10 ml.
All right, so
Okay.
I'm coming out, the needle's coming out. We'll keep this. The other thing you can do is actually nice to do a longitudinal view. Then you can see how much the local anesthetic has spread.
No, I can remove this one. I'm going there. Can you just...
So what you saw was the
Off,
short
off.
axis. Now it's
Off.
turning into the long axis, where you try to see the nerve in the long axis. When you use a catheter with the help of ultrasound, the long axis helps you a lot to place it perfectly well.
So that's good. I'm happy.
Bala, there were 2 pops.
Yeah.
Bala?
There's local anesthetic above the nerve.
Yeah. So that's the longitudinal axis of the
Yeah.
nerve, and the anechoic shadows show the spread of the drug.
Yeah. And if you have a catheter, you can actually follow as the catheter goes in. You can use this view to see how it moves along the course of the femoral nerve. So before we do the obturator, let's look at the lateral femoral cutaneous. It's a very small nerve. Can I have a little bit more gel, please? So the nerve is very superficial. It's not subcutaneous, but it's subfascial. And it is between the sartorius muscle and the tensor fascia lata. So for her, you can see it's beautiful. It's right now in the center of the screen. So you see like a lip-shaped structure in the middle of the screen. On the medial side, the dot side is a sartorius muscle. The lateral side is tensor fascia lata. So that space in the middle is very superficial. It's only 1 centimeter deep.
Can we decrease the depth?
So next is we decrease the depth. Right? So beautiful. You'll see that it's a fat-filled space. You can see a hyper-echoic structure inside. Yes. And if I scan more distally, oftentimes we can even decrease the depth one less.
So the
Yeah.
depth is getting decreased from 2.7, it's
And
come to
then-
2.2. That's beautiful now.
When I go distally, oftentimes you see it split into branches. Not in this case. So this is now, I'm going proximal, and what you don't want to go too proximal because it's going to go on top of the sartorius muscle, it will flatten out. So it's now smaller and smaller and smaller. It is more difficult to see. So now I'm going distal. So I think this is nice. I would just inject maybe 3 mils of local anesthetic there. Okay, so if I'm going to, is she sedated or I use some local? Yeah. We are very kind. So this is, now if for some reason in her case, you'll see a lot of adipose tissue on top, so that is actually very nice. If you find that the nerve is so superficial, what you can do is to layer the gel on top of it and just very gently touch the skin. Then you can, that would help you. That is a wall of local anesthetic. Thank you. Tiny scratch. So usually I just get rid of the excess gel. You know it's going to be very superficial. So I'm just going in now. Pop. Okay. So I'm inside. Again, I don't need to get too close to the nerve. If I inject, I see it go, the local anesthetic goes around, that's good enough. So can you inject half a cc? That's good. Okay, so we can inject 3 mils there, and then that's all we need.
This is called a cloud sign. When you inject it, the local anesthetic, when it is agitated, it produces like a small
Right.
cloud.
So my needle is nowhere close to the nerve, is in a puddle of collection of local anesthetic, so I know I'm very safe. Done. So
that's a lovely demonstration process.
So now we look at the
obturator.
The obturator will usually have the leg abduct a little bit to the side, so we have a little bit more space to the medial side of the leg, of the thigh. And I use a little bit more gel and a bit more depth. For her, we pre-scan it. It's a very nice adductor longus, brevis, and magnus. So we look at the plane, intermuscular fascial plane.
Bala,
Yes,
Dr. Bala, for the femoral, there were 2 pops. What were they?
the fascia iliaca and the fascia lata. Fascia, the one which you have to pierce is the fascia iliaca, just above the femoral nerve.
Okay, so right now, can we come out a little, or maybe move this one out a little bit? Just a little bit more. So here, you see the fascial planes. We can maybe decrease the depth a little bit. Okay, so you see 2 lines, one very deep, deeper, very bright on the medial side where the dot is. It's about 3 centimeter deep. That is one lower down, lower. This one. So this would be between the adductor magnus that is deep and the brevis. Let's see. Yeah, that's right. So you can see the most superficial one is the obturator adductor longus. The second, yes. The second muscle layer is the brevis, and the third layer deep is the magnus. So what you see there are 2 very hyperechoic lines dividing the muscle layers. And as I scan more proximally, you will see that 2 plane is going to merge. And I'm going up, I'm angling the probe up. And it's not as nice. So her legs are not quite well separated. Okay. Okay, so it's not too bad.
So
So oftentimes for this block, the leg, the thigh, a little bit more abducted, that will give you a better space. Right now, I think the challenge is that. So before this session, we pre-scan and I was able to trace the two coming together. But what we can do is we can stimulate the posterior division of the obturator in a very bright area. That would be to demonstrate that the adductor muscle twitch. So
this
okay.
and this. You can see the adductor longus very well. And you should go, probably this is the anterior division and the posterior will lie here.
Okay, tiny scratch. So you can notice that I'm working in a very narrow space. Little ouch. That's a sensitive area.
So now we look for the adductor muscle contractions. That's the end point.
So that's his anterior, that's posterior. Okay, thank you. It's bent.
Actually, because this is at the inner aspect of the thigh, it's not a flat surface, so makes a huge
Okay,
difference.
so
Yeah.
I'm approaching the anterior division. So if you stimulate, you may get some twitching here. Can you use the twitch? Is it? Okay, there it is. Do you see the twitching? Yes or no?
Yeah, we can see, but can you focus it more towards?
Do you see the
Yeah,
twitching
yeah.
now?
Oh, yeah, we see it now, yes.
Okay, so that's the anterior division. Should we inject a little bit here? Yeah, so open up the space. That's nice. So once you inject it, you probably will see the nerve better because it's hyperechoic. Right, so now I'm going to go to the posterior division. Okay, can you stimulate now? So I may be slightly away from it. I don't want to redirect my needle because she is a little bit sensitive. So let's see whether we can get any. So I may have to redirect the needle.
So now trying to go between the adductor brevis and magnus. You see this hyperechoic structure which separates
Okay,
the
let's
brevis
try
and
that.
the magnus. So to confirm, because you see,
Can
don't
you
see the
stimulate?
nerve.
No.
It's a very small nerve. We need to just go into the facial plane separating the two. Try to stimulate it with a stimulator
So
to make sure that
maybe
adductor has
lower
contract.
down. It's hard to, right now it's hard to, yeah, it may be this one. Because you see a very bright area and not what you see is all nerve. So some people would just flood this plane with local anesthetic and that's good enough. Do you want me to?
I think we could do that. We can just flood that area with local anesthetic.
Yeah.
Yeah. The obturator block is very useful when you use a TURBT, very helpful. Most of the times it's like, now he's approaching the posterior branch, which lies between these two muscles. So almost there,
I think
near
it's
the
twitching
facial
now.
line. Yeah.
So now there's the twitching. Okay, well, you can decrease the twitch, and then we'll inject some local there.
So Professor Chan, you would like to get a fusiform appearance of the spread of the drug between the two muscles?
Yes.
That would be your end point.
Yeah, right now, okay, I think the nerve is just below the needle. How much have we given?
1 ml.
Can we give, let's say, 3 to 5 mils there? Yeah. Good. Okay. We can increase the depth a little bit now. I think now you can see better. Okay. Enough. So what else do we need to do now? The next one is the sciatic. Okay.
So what approach you're planning to do for sciatic?
So I usually do a subgluteal approach, but if she is not able to do that, I may try a anterior approach.
No, we would be happy to do a subgluteal approach.
So we'll help to turn her on the
Or
side.
if there is another case for subgluteal approach, we'll go ahead with the anterior approach. Dr.
So-
Sandeep?
What they are saying is we will
Okay.
go to the infraclavicular by the time we
Oh, okay.
position her,
Okay,
and
yes.
it can take some time for the sciatic.
Okay, so we by the time we position, we are going to the next case in the other theta.
Okay.
And we'll come back to you for the sciatic subgluteal.
Okay.
Thank you, Professor Chan, for demonstrating the 3 blocks.